we're going to go ahead and get started. Welcome to the first of a series of webinars for OneCare. This webinar is an introduction for OneCare plans and providers. I'll be your facilitator today. My name is Lainey Bruner-Canute, and I'm with the UMass Medical School. And I'm so very pleased to have as our presenter today, Robin Callahan, Deputy Medicaid Director for Policy and Programs at Mass Health. But before I turn things over to Robin, I have a few housekeeping items and a couple of questions for you. Please note that this webinar is being recorded and will be made available at a later date. Also, we have some accessibility features in case you need captions or other accessibility items. For this webinar, we are using the mute feature on the conference call line. The audio is provided through your phone line, so please call in to 617-410-9095 to join in. For best results, we have found that you should turn off your computer speakers. If you want closed captioning, make sure to click the Show Captions button at the top of your screen. Otherwise, if you don't want closed captions, please click Hide Captions. Even though the phone line is on mute, we welcome your participation, and we have a couple of ways for you to participate. First, there will be a question and answer time at the end of the webinar. We'll give you specific instructions at that time. Also, during that time, we'll start off with some of the questions that came in through the registration process. Second, we will be polling you throughout the presentation. A question will appear on your screen, and you can choose your answer. We'll wait about 20 seconds or so, and then the results will be revealed to everyone before we move on to the next slide. You may not be able to view the entire slide right now. If that's happening to you, you may need to scroll in order to see the full slide. You may also reduce the size of the slide by pressing the Control and minus keys at the same time. Your screen view will be updated once you refresh your browser or when the presenter moves on to the next slide, which I'm going to do right now. We wanted a chance for everyone to find out a little bit about who is attending this webinar. OneCare is bringing together a lot of different experts. So right now, we'd like you to answer the question, what is your primary area of expertise? You can select as many answers as apply. We know from the pre-registration that we had a wide variety of primary care, care coordinator, behavioral health, and long-term services and supports folks. And the results of this first polling question are so we have the highest one is other, which sort of makes sense. And then we have behavioral health and care coordination and care management. So as you'll see, OneCare encompasses all of these areas. The next polling question is about in what part of Massachusetts do you provide most of your services? Again, you can choose as many as apply. OneCare is statewide, so we hope that we are seeing a good representation of folks from all areas of Massachusetts. And we'll just give a few more seconds for folks to enter their answer. So a lot of folks are coming from the Boston area and from Central. Welcome everyone to the webinar. Today's webinar will give you a high-level overview of OneCare. Future webinars and other training efforts will provide additional, more specific information. After today's webinar, you'll be able to describe the essential and unique elements of OneCare, identify characteristics of the OneCare population, explain how care will be delivered and what services are available, specify eligibility criteria and enrollment processes, and summarize enrollee rights and protections. To address these objectives, I'll now turn things over to Robin Callahan. Take it away, Robin.
Okay. Thank you, Lainey. Thank you very much. And I really want to thank all of you so much for participating in this webinar today. We're really excited to be talking to you about OneCare. And you might have heard over the last year and a half or 2 years, Mass Health, CMS, and a large number of stakeholders have been talking about something that we've called a duals demonstration. And we're happy to be able to give it a name, and it is called OneCare. So OneCare will be for us a new option that we're able to make available to people aged 21 to 64 who are eligible for both Mass Health and Medicare benefits, otherwise known as dual eligibles. This will enable those folks to receive care as part of a single plan, offering comprehensive benefits that cover both the Mass Health and Medicare programs. The services that will be covered by OneCare are all Medicare services. Those are Part A, Part B, and Part D, inpatient, outpatient, and pharmacy. There will also be available all Medicaid state plan services that the dual eligibles are entitled to. And most importantly, those include long-term services and supports that we'll talk a little bit more about in a minute. But those are services that are offered by Medicaid, but not offered in Medicare. And generally, they help to support the functioning level of our members. OneCare will also include behavioral health diversionary services. These are a set of community-based services developed to help folks with significant behavioral health issues to receive support in a community setting. What we've also made available through the OneCare program, or will make available, are some additional flexibilities that we hope will be important for folks that enroll, that would offer some community support services that can be used in a flexible way in a care plan that are not available to this group of folks in the fee-for-service world. So we hope that all of these aspects of care, all these domains of care, would be brought together, and the point is to integrate them in order to improve quality of care and hopefully over time to have a more cost-effective way to provide care. Why are we doing this now? I think that for those of you who've worked with folks who are dually eligible, you have known that the Medicare and Medicaid programs have not had the type of integration that supports care across all domains of care for these folks. Certainly services different sets of services are provided by the, but they are not really brought together, and there certainly isn't in the fee-for-service system anything that is helping our members manage their care. We've recognized this, and so has the federal government, so that there was a special program authorized under the Affordable Care Act as federal health care reform, in which Massachusetts was one of 15 states awarded a planning contract from the CMS Center for Medicare and Medicaid Innovation, which encouraged states to develop approaches to integrating care between Medicare and Medicaid. So that the grant that Massachusetts received was to help support the development of the design of OneCare. The goals of OneCare are very important. The first goal is to improve health and functional outcomes for our dually eligible population. We're going to see a little bit more in future slides some characteristics of the group of people that we're hoping to serve under OneCare that make this a particularly important and frankly challenging goal. We intend for OneCare to be based on a model of person-centered coordinated care. We want to see that more and more in the way the Mass Health program and I believe the Medicare program delivers its services to people. We are interested in seeing a reduction in the fragmentation of care, where we each sort of provide our own one-off services here or there, but there isn't an awareness and an assistance for the members receiving that care to bring it together in a way that makes sense for them and optimizes the benefits that these folks have entitlement to. We're also looking to move from a fee-for-service focus on how services are delivered to a more outcome focus. So we don't want to pay by the widget. We would like to pay by how services are combined to produce a better outcome that is measurable. We're also trying to address cost shifting between these programs. I'm sure as providers you're probably aware that back and forth between Medicare and Medicaid sometimes as to who should pay for service. There are hoops that providers have to jump through to bill one and then another. There are denials that you need to get on one bill before another program will pay for it. These are cost shifts, and these come about when programs are not aligned. And I think, a major goal of OneCare is to create alignment between Medicare and Medicaid so that the cost of cost shifting can be transferred into actual provision of services. And another thing we have to think about is that for both the Medicaid and Medicare programs, there has been a trend of growth and cost that has to be addressed somehow. We, in developing OneCare, we're saying we have a solution that we think can work, that we believe there is a window in which we can improve service delivery while at the same time bringing down costs, diverting people from more expensive care into more community-based care, which not only is less costly, but certainly suits the preferences of our members better. So again, the general care model for OneCare is going to be based on providing person-centered care, understanding that there is really no one solution for each person. Each person has to have their own solution to how the care comes together and how they can get the most out of their entitlement to benefits. So this is what we're proposing through OneCare is care based on the goals and preferences of the individual, looking at their situation in their own terms and figuring out with them the best way to put together a package of services that makes sense. There's a focus on the individual. Again, you will see as we talk more that there's a assessment process and a care planning process and a care team that is for a given enrollee or individual and will look different from person to person depending on what issues are present and how that person would like to receive their care around those issues. So the individual is going to be involved in the care team activities. They're going to attend meetings. They're going to be expressing their preferences, talking about the options, and their involvement is to be respected and to be integral to the care plan. So we're looking for a program that focuses on meeting health needs, meeting functional needs, but doing so with recognizing choice, dignity, respect, self-determination, and purposeful living for the folks that would be enrolled. So who are the target populations for OneCare? Well, who are the folks we're talking about? Well, as you know, there are generally two ways to be eligible for Medicare, and that is through age, if you're over 65. But if you're under 65, as this target population is, you get eligible for Medicare based on the fact that you have a long-term disability. So everyone in the target population for OneCare will be a person with a disability. These are going to be adults with physical disabilities, intellectual or developmental disabilities, serious mental illness, substance abuse disorders. They will involve folks that have multiple chronic illnesses or functional and cognitive limitations. And we look at some of the social manifestations of that, one of which is homelessness. We think that we have in this population group a significant section of folks who are homeless. When we look at eligibility, again, we have found in our sort of set of options in Mass Health that while we have options around coordinated care for many populations, for example, elders have access to a program called SCO, Senior Care Options, which is similar. There are a group of folks with disabilities who are between the age of 21 and 64 who currently do not have an option available to them to access integrated care. So that is the target population here. So this is a person who will be between the age of 61 and 64. They'll be eligible for Mass Health Standard or Common Health. They will be enrolled in Medicare Parts A and B and eligible for Part D. For the time, our target population will not include those that have other comprehensive insurance. In other words, the only two coverages that this person has will be Medicare and Medicaid. For our initial program, we're not going to be enrolling people who are in other comprehensive programs like PACE, that's Program of All-Inclusive Care for Elders, SCO, or home and community-based waivers. Those folks will not be in OneCare or be able to enroll in OneCare. And they would not be residing in this term ICFMR. This is just a term for certain types of residential programs for people with developmental disabilities. At this point, would not be included, would not be enrolled in OneCare. When we look at the characteristics of the OneCare population, we see some very interesting facts that really drive the types of services and the type of models that we think is important. We see that there are about 67% of a target population, and again, the entire target population that I neglected to say is about 111,000 folks, who have behavioral health diagnoses or serious behavioral health issues, about 50% with chronic medical issues, about 8% with intellectual or developmental disabilities. About 25% currently use long-term services and supports, and these are services that address functional challenges, services like personal care attendance, home health, rehabilitation, nursing facility. And about 96% of the target population resides in the community, the other 4% in residential long-term care facilities. Care will be delivered in the OneCare plan through a care team and a provider network through the health plan. There will be an integration of primary care, specialists, behavioral health, and LTSS, long-term services and supports. There will be a person-centered assessment for each enrollee, planning and service delivery, using a medical home or health home type of model as its foundation. The care teams will be comprised of, you'll see on the slide, an enrollee in the middle, and that's exactly what our intention is, that enrollee is in the middle of the care team. They're not outside the care team. They're not hearing about things from the care team. They are an integral part of their own care team. Each member will be assigned or have a care coordinator that is their major point person to connect with their health plan, that is available to them at all times. Folks that have serious or complex medical needs will have access to a clinical care manager. On this team will also be their primary care provider, a behavioral health provider if that's indicated, and long-term supports coordinator if that is indicated as well. and the enrollee must play the central role in the care team. You'll see that the care team could be many more folks, depending on the enrollee's preferences and needs and who is involved in the life of that member, of that enrollee. So it could include, family, peer support, advocates. Folks might be involved with state agencies that are providing a good deal of support already that they want to be involved in a care team. We're asking that the health plans that offer OneCare are creative about bringing in new and different types of workforce, such as community health workers that may support people in their wellness objectives or disease management goals. But this will really be a personalized care team. So one of the questions that we have for you today is, have you ever been involved in a person-centered care team? And if you could let us know that, we'd appreciate it. As we're waiting for the results to come in on that question, we'll go to the role of a care coordinator. This is critical. What we hear from many, many people as they're trying to navigate the benefits of the Medicare and Medicaid programs is, while the services might be out there, we need someone to help us access them and make sense of them. So that is the role of a care coordinator. This person will ensure the completion of a person-centered individual assessment within 90 days of enrollment into the OneCare plan. They will be responsible for coordination, monitoring, following up, and scheduling care team meetings, and making sure that the plan is actually delivering for the enrollee. We mentioned before that there's a clinical care manager who will be assigned to enrollees who have particularly complex care needs. We find that many of the folks in the population that we expect to enroll in OneCare have multiple diagnoses or multiple issues that they're trying to manage at the same time. There will be expertise around about managing them. We've also introduced a role called a long-term support coordinator. And this is a person who's meant to be or will be independent from the health plan. They will be contracted by the health plan as an expert in long-term services and supports and community-based support. So they will bring to the care team, to the member, expertise around long-term services and supports. They will advocate for the provision of those supports in the care plan. They'll help to facilitate community integration for the enrollee, and they will assist the enrollee in accessing personal assistance and other services. The personal care plan is going to be a major feature. The first thing that will happen once a person is enrolled is they'll work with their care team to develop a plan. It will be informed by a comprehensive in-person assessment directed with the enrollee, and it will cover the whole range of medical, functional, behavioral health, and social and support needs that person has. If the care plan that the member is presented with at the end of this process does not meet their needs, or the enrollee doesn't believe it reflects their needs, they have the right to appeal that plan. Polling question. Another question we have is, do you currently work with any members who receive both Mass Health and Medicare?
Okay, and Robin, if you could just give folks a few seconds to answer the question, please.
Okay. Okay. I'm going to talk a little bit about the enrollment process for any given enrollee. When a person enrolls in one of these OneCare plans, well, the first thing we're going to do is offer OneCare plans to folks that would like to choose to be in it. And we're going to send out to the entire group of 111,000 eligible members a letter from Mass Health with enrollment information about OneCare plans. At that point, folks can choose to opt in, which means they can select a plan, or they can tell us that they do not want to be in OneCare. There will be a lot of information between now and when we get to that point for people in the community who are helping members make that choice, providers, community-based organizations, and others, to get the information they need to help our members who are eligible to be in OneCare. So Lainey is going to talk about, at the end of this presentation, what you can expect in terms of more information. In the next phase of the program, we will start to do some auto assignments for folks. And these are for people who don't make any choice at all. They don't tell us they want it. They don't tell us they don't want it. We will start to have a process where we will approach them and say, hey, here is a plan that we think might work for you. They, again, will have the option, and that will happen at least 2 months before an enrollment is effective. They will have an option to say, okay, that's fine, I agree with that. Or they can tell us at that point, either I would like a different plan or I really don't want to be involved. So there will be these opt-in and opt-out features that we don't really see in any of our programs today. So the choices the enrollee has, as I said, is they could enroll, they're going to be able to enroll or disenroll from any given OneCare plan at any time. They'll be able to choose a different OneCare plan at any time. They can say, this is not right for me, but I think this other one might be. That is in the context of understanding that enrollment in a OneCare plan is from month to month. So a person is enrolled in a plan for a month. If they say they don't want to stay in, then we will change that enrollment at the beginning of the next month. There may be situations under which a member who's enrolled in a OneCare plan would have access to certain non-network providers. There are going to be rules around that. We certainly hope that that will be the exception rather than the rule, because, again, we think it's very important that the providers that our members who are enrolled with are a member of the team that's set up by that health plan. So we will try very hard to make sure that the providers that are important to our members are participating in the health plans so that our members can get full advantage of the new program. There will be enrollment assistance through a Mass Health customer service, trusted state agencies, and community resources. And there are counselors out there called Shine Counselors, which currently provide counseling to Medicare beneficiaries generally about the options available through the Medicare program. And we will be working with them specifically to educate them and make sure that they are comfortable and have the information they need to help dually eligible members who could be enrolled in OneCare understand that program as well. It's important, as we talk about this, that you know as providers that a big part of the decision-making that members are going to make about whether to join or not is whether their trusted providers, their programs that they're already enrolled in, are members of these health plans, these OneCare plans. So we really hope that you will be participating with our members in joining up into these plans. This slide talks about an assessment timeline and what our expectation is when a person enrolls. Once enrollment is complete, there is a 90-day period that the enrollee keeps the current providers and services that they are receiving at the point of enrollment, so that there's no disconnect, there's no gap, there's no interruption. During that 90-day assessment period, it's our expectations that health plans will make sure, through their care coordinators, that each enrollee is met with and a personal care plan is developed. And it is not until that happens that the person will perhaps, if necessary, see an adjustment toward the network providers. It is critical that any need that the person has be addressed right away, and I think of particular importance to us is understanding that there are people that are receiving long-term services and supports that they use every single day. So we want to make sure that when they enroll into a OneCare plan, there is no interruption in their lives or their ability to function because there is a change in really payer. So, and speaking of continuity of care, the OneCare plans have to provide written notification if the personal care plan proposes changes to how their services are authorized. So there's this 90-day process where they're working with this new enrollee, talking about what their needs are, and if they're going to change anything, they have to provide written notice to give the member a chance to understand whether they think that's going to work for them or to register any objections or appeals. We want to make it clear that we want the clinicians and providers and the folks that are working with our members now, particularly our members with disabilities, we want them to bring their expertise into these care plans. So there is activity going on right now through the health plans, and we'll talk about who they are in a minute, to set up their provider networks. I believe that, you'll be very welcomed in these provider networks, and again, it's very important that you join in order to become part of the care plan that the folks that you're working with now are going to have access to. There will be an official grievance process for people who enroll where they can file if they have a complaint about the care plan that they're in, the health plan that they're in, to make sure that we are monitoring and have a process to make sure people are treated with respect and can get answers to their questions and are able to develop positive and effective relationships right away with the OneCare plans. There are particular timelines about response to those, and there is access to the Medicare and Medicaid processes and enrollee protections for folks in this process. And we'll be talking a lot more detail about grievance and appeal processes in future webinars. Importantly, any time that one of the health plans denies, terminates, suspends, reduces services, or causes any kind of delay in service, is certainly an appealable action. It is our intent to be very, very vigilant about making sure that folks that enroll in these new OneCare plans have full access to all of their appeal rights through both Centers for CMS and Mass Health Board of Hearings. So that more information will be coming out about that soon. Another line of protection that we will bring into this process is the role of an ombudsman. We are now in the process of a procurement. Mass Health is procuring for an external party to provide services for people to help us identify sort of systemic complaints or difficulties, to provide advocacy for enrollees in a way that enrollees are assured that this person is outside of the system and can speak without conflict and advise us about how the system is going without conflict. Because the entire target population of OneCare are persons with disabilities, attention to ADA compliance is going to be key. We're requiring every plan to designate an ADA compliance officer, provide us with a plan, so that we can see what they've done in terms of providing reasonable accommodations, ensuring access, and we're talking about accommodations such as communication, access to ASL interpreters, physical access to the physical plan and the equipment and doctors' offices, flexibility in scheduling. This will be a high area of interest as we roll this plan out. So who are the prospective OneCare plans? At this point, through a procurement, Mass Health is working with, Mass Health and CMS are working with 5 health plans who have come forth to say they wanted to offer this program. Those are Blue Cross, Blue Shield that has a new plan called Blue Cross Partnership, Boston Medical Center HealthNet, Commonwealth Care Alliance, Fallon Total Care, and Network Health. They're working with us now on readiness activities to participate in OneCare. I have to caution, though, that until we get to the point of signing contracts with them, they are not actually OneCare plans yet. We're working very hard to get them there. They're in a process now of something called a Readiness Review. They have to pass a number of hoops that the state and federal government has set up for them in key areas that we're looking at, or what their process is around care coordination, what their network adequacy is, which is why you might have been working with them or hearing from them or negotiating with them about joining their networks. We need to make sure that they have in place appropriate enrollee and provider communications, that their computer systems relate in the way they need to both the Medicare and the Medicaid systems, and they have the appropriate organizational structure and staffing to take on the enrollees of OneCare. Plans that pass this and are in a state where they continue to want to be in this program will then go on to sign a 3-way contract between the health plan, Mass Health, and CMS. How will they be paid? The plans will be paid in a capitated way. They'll get sort of a 3-part capitation that will consist of a certain capitation for the Medicare A and B payment, a separate one for the Medicare D, and then there'll be a capitation based on what the Medicaid portion of the services. So you'll see that there's risk adjustment through a typical sort of Medicare Advantage risk adjustment process. A Medicare Part D risk adjustment goes on. And on the Medicaid side, we've developed rating categories that are based on the needs, the long-term service needs and behavioral health needs that sort of stratify into different payment rates. We are also encouraging OneCare plans to use alternative payment methodologies for their provider contracts. And many of them have in place certain shared savings arrangements or primary care behavioral health integration arrangements that they are pursuing, and we encourage that because we think that that will add significantly to the involvement of providers and share savings that might be accrued from controlling for unnecessary hospitalizations and institutional care and readmissions. How will providers be paid? So providers, again, are being, I think each of these health plans are reaching out to the provider community to form their networks. The health plans will negotiate directly with providers on the payment rates and methods. The rates will not be set by either Mass Health or Medicare. However, we have encouraged all involved parties to look at the current Medicare and Medicaid fee-for-service payment as a baseline or starting point for negotiations. So during the 90-day continuity of care period that I talked about earlier, where for the first 90 days of enrollment, the health plan is not allowed to change providers. They have to wait for a care plan to be developed. The payment rate for those services will be current Mass Health or Medicaid care fee-for-service rates. That is how the plans will pay the existing, perhaps out-of-network providers during this 90-day period. Quality and reporting will be really a high priority. It is very important that we look at not only the spending levels, but making sure we don't see reductions in spending that are due to bad care. We need to see both a high level of quality, improving quality of care as we go along, and we'll be monitoring that very closely, and we'll be working with our stakeholders, including an implementation council. That's a very important part of this project that is built with half of the implementation council are consumers and another half are providers and other interested parties that will help advise us and watch this program as implementation takes part, so we'll get some input into what we need to track, that the program gets a good start, that we can make any adjustments necessary, and part of that tracking will be to constantly be looking at enrollees to see what their level of satisfaction is as they start to join these new programs. So, in conclusion, I think that we're very excited to be offering a new model of care for a very significant population group. This is a group of people who receive and are entitled to both Medicare and Medicaid benefits. They are the highest cost and most complex need population in both programs. It's a group that ironically currently does not have access to integrated care. We really very strongly hope to fix that in a program that we hope to launch this fall. And the goals are clear for us: enhancing the focus on person-centered care and outcomes, reducing cost shifting, lessening our reliance on acute care. It's a very important feature, acute emergency care. A model of care that can serve the enrollee in their own culture, in their own community, therefore to focus on community-based services, both for long-term services and supports and for behavioral health services particularly, and reducing fragmentation of care, where a person just has to pick up a phone book to figure out how to get help with services. We'd like to see that rectified. We'd like to see a very cohesive, integrated, supportive model of care for these very complex members. So we're excited about this, and we really hope to work with you over the next several months to bring this program up. And again, thank you very much for your time and attention.
Right, and so now we're going to have some time to ask questions. So to ask a question, please just click the Ask a Question button at the upper left-hand side of your screen. Type in your question and click Send Question. We'll answer questions in the order that they are received. Now, I just want to let everyone know that we may or may not be able to get to all the questions today. We'll try to answer as many as possible, but we will definitely be taking these questions and using that information to help with content for future trainings and other activities that around the OneCare. You may also be able to find additional information to answer your question at the mass.gov OneCare website. Now, as I said, we're going to start with some of the pre-registration questions. So the first question we have for you, Robin, is how will our patients learn of OneCare, and what additional resources will we need to have to enroll our patients?
Thank you. I think, the most important thing for you to know at this point is that we're now embarking in a public information campaign that we're starting, that has recently started, and will really be in place throughout the duration. We believe that the One Plan, our target is for the One Plan enrollment to launch sometime this fall. So between now and then, we have planned a lot of information to go out. There is currently a website called the Duals website for now that we're setting up a OneCare space for, that we'll be putting information up over time. We have a consumer guide, something called Introduction to OneCare coming out. We have posters coming out. We have flyers. We have FAQs that will be posted. We're also in the process of developing some community meetings that will be coming out. As Lainey said, there will be additional webinars for providers. So we believe that we have many, many different places and ways. We'll be reaching out to community-based organizations, meeting with them, meeting with consumer groups from all segments of the disability community. So this will be, we're just starting it. Right now we're trying to get very high-level information out, but you can be sure that as we get closer and closer to implementation, you'll be seeing more, and we'll be providing you with specific information about how to get the information you need to support your patients or your the persons that you're interested in helping through this process.
Great. Now, a question that's on a lot of people's minds: what is the effective date?
Okay. Well, I think we have had, for those of you that have been following this project for a while, we've put a number of different dates out over time. We're, I believe, at the point in the process where we can start to see much more realistically when we'll be able to launch. And again, we're right now using fall of 2013 as our, I know it's not pinpointing a date for you, but you can expect that sometime in the fall we will actually start enrollments. We expect to put out probably within the next month a more specific timeline. We are now looking at where the prospective OneCare plans are in their readiness, what their provider networks look like to date, how much more time they're going to need for that. And then there's a process we have to go through to actually get contracts signed. So I believe that we'll be seeing in the next month a much more detailed and definitive timeline.
Great. And finally, the last pre-registration question. We just talked about time. Now we're going to talk about money. What are the fee schedules that will be used?
As I said, in this model, the health plans or the OneCare plans will be negotiating directly with providers to provide the services. So there will not be, Mass Health will not be setting rates per se. What we have asked the plans to do is look at the fee schedule that exists today in Medicare and exists today in Medicaid, and involve in negotiations using that as sort of a guidepost. It doesn't mean they're required or to offer them. It doesn't mean that providers are required to accept them, but we think that's the right place to start, because what we're in effect, what we're going to be doing is we're really funding these health plans through what we currently pay for fee-for-service. The idea is that paying for a care plan through OneCare, a program like OneCare, is a better way to pay for services than fee-for-service. So there isn't new money, so to speak, coming in. The current estimated cost for the target group that we're talking about right now is about $3 billion a year in spending. We don't expect, or it's not our goal for that to increase dramatically or at all, so we have to all be conscious of that. We do have a budget of sorts. But we also, the reason that we've asked for the health plans to use the current fee-for-service structure is it is important to us that the folks that have been providing faithful service to our members for all these many years in the fee-for-service world are not disadvantaged financially by us going to this model. On the other hand, it's not meant to be an opportunity to to do a lot more than what we see in fee-for-service spending. So I hope that that's close enough to an answer to you, and I really would hope that there's, and expect that there is good faith on both sides of these negotiations. The health plans need an adequate provider network. Our members need experienced providers. And I think that as we see that the OneCare plans offer a lot more to our members than fee-for-service, does. I hope on the provider side you understand that you need to be involved in one care plans so that your patients are able to take full advantage of what those plans have to offer.
Great. Our first question online is, what is auto-assignment criteria?
Okay. Auto-assignment, just for those of you that don't know, is when when Mass Health determines that a person is in the eligible target group and chooses a plan for that person to enroll in. Now, Mass Health will only do that if the person either has not expressed another choice, has not told us that, and has not told us that they don't want to be in one care. So under those circumstances, we will auto-assign a person. The first thing is they have to meet all the eligibility criteria that I talked about earlier, that they are eligible for both Medicare and Mass Health Standard of Common Health. We will not be auto-assigning anyone who is already in a PACE plan or a Medicare Advantage plan. We will be looking in our system to those who have opted out. In other words, when someone tells us, I don't want to be in the plan, we put that in our system so our system knows not to auto-assign that person. What will happen when someone is auto-assigned is we will send them a notice of that at least 60 days before the enrollment is effective to say, you know, there's this new health plan. We had already given you information about it. Here is some more information. Here is a plan that is available in your geographic area. We would like to enroll you in this plan. Your enrollment will be effective in 2 months. Let us know if you don't want it. Let us know if you want to change. So we expect that auto-enrollments will happen in sort of groups over time. We will not start auto-assignments until after we've had a significant amount of time to fully inform people about their one-care options so that they can choose, at will, so that they can have conversations with those people who can help advise them. So they will have a lot of time to sort of pick a plan. After a number of months, then we'll start to auto-assign certain groups of people, and our plan right now is to start with folks who our data shows us are some of the less complex cases and the folks that have the less complex need. That's where we will start, and we will sort of move from there as we get more experience with the program.
Okay. Is there one person on the care team who approves the final care plan before it is operationalized?
The care plan is a collaborative process. The enrollee is the major player. Their major contact, their primary contact person through the care plan process is their care coordinator. So once the care plan is developed, it will involve care team members across the whole spectrum of care the person has needs for. So if the person has particularly high behavioral health needs, I'm sure the behavioral health provider will be very prominent. That might not be the case in someone who doesn't. There might be a more prominence with the long-term support coordinator for a person who has sort of physical functional needs. So it will really depend on the individualized situation of that member. The important thing is that, and the care coordinator will go about all of the internal health plan processes necessary to gain approvals for the services that the care team advises. So there will be health plan authorization processes that are specific to health plans, and you would want to talk to the specific health plans about how they work. But in the final analysis, if the care plan that results from that should be something that the member agrees with and understands. And there are many, as we mentioned in the presentation, avenues for that member if that turns out not to be the case.
Okay, thank you. Can you clarify the difference in roles between the care coordinator and the care manager?
Sure. This is an either-or role. A person won't have both. Generally speaking, the major touch point for an enrollee with regard to the plan will be their care coordinator. However, we're going to find that there is a fairly significant portion of the population who will enroll who have very complex medical needs. And what we expect is that those folks, once they've been identified as having those needs, will, instead of having a care coordinator, will have a clinical case manager. This is a person with specific clinical expertise that is more specific around being able to coordinate medical services than a more generic type of care coordinator. If a person has a clinical care manager, they will not also have a care coordinator. That person will serve as their care coordinator. So I hope that distinction is clear.
Okay, great, thank you. Someone is asking for a clarification. Individuals can use their non-contracted providers for 90 days. Does that mean that they must be able to use them for 90 days, even if a care plan has been developed prior to the 90-day period?
Right. Well, what we've said is that if a care plan is developed prior to the 90 days, only if the member fully agrees to that can the health plan end the continuity of the fee-for-service providers that they had coming in. Otherwise, if there's any question about that, if there's a challenge to it, if the health plan hasn't gotten around to finishing it, the 90 days is guaranteed to the member. It would have to be with the full consent of the member to have anything short of that.
Okay, and I think we have time for just one more question, but please feel free to email your question, keep on entering your questions, and we will be using that for information for future trainings. Will the initial mailing to the duly eligible have clear markings or alerts on the envelope so that beneficiaries will easily recognize this?
Yes, that's a very good point, and we've heard that a lot. Of course, we are going to do a lot of mailings, and we will be doing very specific markings and making sure that the general community knows what they look like so that they can help our members know that this is a very important piece of information is coming their way.
Great. Well, thank you so much, Robin. And as Robin mentioned throughout the webinar, there will be a lot of opportunities for more training and more information in the months to come. You can either click directly from the webinar or copy and paste the link into your browser. We hope you'll also take the time to give us some feedback on this first webinar as well. Thank you so much, Robin, for presenting today, and thank you to everyone on the computer for your participation in this webinar. Have a great day.